Welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday evening edition. It's my great pleasure to introduce a close friend and colleague, Dr. Carlo Pelino. He's a graduate of the Pennsylvania College of Optometry. He also did a residency in ocular disease at the JFK Memorial Hospital in Philadelphia, where he concentrated in retina and neuro ophthalmic disease. He's currently a full-time assistant professor at the Pennsylvania College of Optometry at Salus University, where he serves as Director of Optometric Retina Services at the Eye Institute and Chief of the Chestnut Hill Satellite Clinic. In 2005, he completed a one-year retinal fellowship emphasizing medical and surgical treatments under the direction of vitreoretinal surgeons at Crozier, Chester, and Riddle Memorial Hospitals in Philadelphia. He's a fellow of the American Academy of Optometry, where he completed his two-year term as chair of the Retina SIG. He is the Chief Optometric Advisor to WebMD. He is a strategic advisor of numerous companies. He has worked with the University of Pennsylvania on retinal research projects. And he lectures regularly in domestic and international programs. He's got a topic of great interest to me. I'm sure it'll be great interest to everybody else. And I know he's going to do a fantastic job. We've had Carlo before, and that's why we keep having him whenever we can get his services. So with that, please give me a nice virtual welcome to Dr. Carlo Pelino.
Thank you, everyone. Joe, Greg, thank you for inviting me. Can you hear me okay? Nice and clear?
Yep, you're good, Carlo. Perfect.
Okay, thank you, everyone. So as Joe had said, we're going to talk about neuro ophthalmic disease tonight in the optometric practice. I'm going to go at a nice pace. I have about 97 slides, I think, and we have about 100 minutes. So it'll be a nice pace, and you know, I'll stick around later to answer your questions if we need to. So the disclosure statement is that I have nothing to disclose. And once again, the title of this lecture is Neuro Ophthalmic Disease in the Optometric Practice. If at some point you have a question for me, feel free. My telephone number is there, 215-276-6180, and my email is cpelino@salus.edu. As Joe had said, I'm at the Pennsylvania College of Optometry in Philadelphia. So to get this lecture started, obviously this is not the title of the lecture, but however, if you look at the top of the slide, emergencies versus urgencies, we have to encounter these daily. A proper triage is needed, and the true emergencies are what I would call the 10A club. Now, we are going to deal with some optic nerve swelling tonight, and I put that in there, papilledema. So we always have to figure out, is this an urgency or is this an emergency? And you're the one that makes the call for the triage, not someone at the front desk of when that person is coming in. The rest that you see here, we may touch on a little bit tonight at the end, the giant cell arteritis and so forth. We'll look at maybe a central retinal artery occlusion, but I'm going to mainly focus tonight in the cerebral hemisphere. Now, to start the lecture off, I think this is important. I like this slide. I think it should be highly looked at and studied to an extent. You see at the 5 weeks after conception, you have a 5 vesicle brain, so 5 and 5. And what's important to remember, let's just look here. The telencephalon becomes the cerebral hemispheres. The diencephalon becomes anything thalamus. So thalamus itself, the epithalamus, the subthalamic nuclei, or the hypothalamus. And you'll see why that's important coming up. You see the mesencephalon becomes the midbrain. The metencephalon becomes the pons and the cerebellum, and the myelencephalon becomes the medulla oblongata. So that the 5 vesicle brain. Now, why is that important? Because if you look at this, everyone, the diencephalon, remember, I'm going to show you coming up here, some people believe that the optic nerve's origin is not the retinal ganglion cell, but the actual lateral geniculate body of the diencephalon, the thalamus. So the eye is an extension of the brain from the diencephalon. Now, that's important. We want to look at, it would be the second vesicle. The other thing that I want to make known here tonight for tonight's lecture is that within these 5 vesicles, if a cavity forms, we're going to get the ventricular system. So if a cavity forms in the telencephalon, we're going to get the lateral ventricles. If something forms in the diencephalon, you're going to get the 3rd ventricle. And if a cavity forms in the metencephalon, we're going to get the 4th ventricle. So keep that in mind with the 5-vesicle brain. Now, as an optometrist, I don't need to really go over this with you, but for tonight's lecture, I will, so that we're all on the same page. And I want to go over this just rather quickly. We know the retina has 10 layers. We know that the ganglion cell axon becomes the optic nerve. The nerve becomes the chiasm. You can see my hand here, correct? Where the pointer is? Okay,
Yep,
thank you.
you're good.
So the optic nerves become the chiasm. The chiasm becomes the tract, as you can see here. And then the tract synapses in the lateral geniculate nucleus of the thalamus, the diencephalon. From there, you go into your optic radiations to your visual cortex. We all know that as an optometrist. Now, one thing that I want to show you that's very important, this is just a clue, and I'll talk about this later. That ganglion cell, the axon it's very long. Look how long this thing is. You have to go through the optic nerve, the intraocular, the intraorbital, intracanalicular, and then intracranial portion until you get to the chiasm. So you need a lot of mitochondria here. Then you have the chiasm where the nasal fibers cross, and then you have your tract where, once again, the synapse occurs. You cannot get a relative afferent pupillary defect, no RAPD, after the lateral geniculate body. So everything in front of it, you can. Anything posterior in these optic radiations, you cannot clinically get a relative afferent pupillary defect. So that's something I want you to keep in mind as we go through these cases tonight. Here is another important, let's say, visual learning tool, exactly what I just said. The optic nerves have been cut, everyone, but they would be here. Here's your chiasm. And then what I want you to focus on, we need to know the anatomy of this visual pathway to make sense of it when something isn't straight up. Whenever you get a curveball, you want to know this anatomy. And what I want everyone to pay close attention to is look at the tract. The tracts hug. You see Mickey Mouse here, it looks like Mickey Mouse. Here we call it Mickey Mouse midbrain. You know, if you've got Mickey Mouse in your view, whether it's a histopathological cut or it's an MRI or an MRA or whatever you do, you know you're at the midbrain of the brainstem. But look carefully. You see Mickey Mouse's ears? These are called the crus cerebri. And in the crus cerebri is your corticospinal tract, traveling from the brain through the brainstem into your spinal cord to move your arms and your legs. So the tract hugs Mickey Mouse's ears, which is the crus cerebri, once again. And then let's look at a couple other features, everyone, for tonight's lecture. Okay, a couple other features here. We want to look carefully, look at the anatomy of our visual pathway that we deal with daily. Look at the anatomy. You see these 2 bumps. These are the mammillary bodies. This is part of the hypothalamus created for memory. So you damage the mammillary bodies, you're going to lose your memory because the information from your hippocampus is going to the mammillary bodies through the fornix. So it's in very close approximation to the tract. You also have your pituitary here. You can't see it, but the infundibulum of the pituitary is very close to this chiasm, as you know. And one final thing I'd like you to look at. You see cranial nerve 1? Here is the frontal, frontal lobe. Here's the olfactory nerve. And look carefully, the olfactory nerve will split. It will go to a medial lateral, it will go to a medial olfactory process and a lateral olfactory process. The medial and lateral, and in between is the anterior perforating substance, very important to feed the brain, especially the basal ganglia. So we'll talk about this coming up. So cranial nerve 1, medial process olfactory, lateral process, and the anterior perforating substance. Now, here, once again, Mickey Mouse, you see Mickey's mouth. This would be the cerebral aqueduct, right? And then you see the lateral geniculate body of the thalamus. And then your optic radiations. So I want to keep this in mind. Please understand the anatomy, because when I go over these cases, if you understand this, which I know you all do, this will make a lot more sense to know your neighbor, right? And the pathway that we deal with on a daily basis, or almost a daily basis. So this slide and the previous slide, something to keep in mind. Now, I want to show you one other thing. Please remember, this is the midbrain, as I keep saying. Cranial nerve 3, remember, these are the crus cerebri, also known as the peduncles. And this is the interpeduncular space. So cranial nerve 3 will leave this way and head towards the eye. Cranial nerve 4 will leave posteriorly, as you all know. Okay, so once again, Mickey Mouse midbrain. Now,
Hey, Carlo, can you go
yes.
back?
Yes.
Can you just show the lateral geniculate body, and fibers do loop around back through there and some go to the back? Can you just explain what happens in that lateral geniculate body?
Sure. So there will be a few slides coming up, but what I'll do here, now remember, the thalamus sits above the midbrain. So the fibers are not running straight ahead. The fibers are actually going up at an angle, about a 45-degree angle. About 90%, 85% of the visual pathway, because remember, we have an accommodative pathway, we have a pupillary pathway, and we have the retino-hypothalamic tract for our circadian rhythm. Those other three pathways may not necessarily go through this, but what I'm showing you here, as Greg had asked me, what I'm showing you here is the visual pathway. So about 90% of the fibers leaving each eye will go through the visual pathway. And what happens is, as they come around the crus cerebri, Mickey Mouse's ears of the midbrain, they go up at an angle and they will synapse in the lateral geniculate nucleus of thalamus. So Greg, right here, as you were pointing out, right here is their synapse. Anything behind that, as I said earlier, if you lesion the temporal lobe, parietal lobe, or occipital lobe, there will be no afferent pupillary defect. Okay. Now, another thing I think is important that Greg brought up, I think it's good to do it now. If you lesion the tract, you're going to end up with a homonymous hemianopsia, just as if you lesion the optic radiations. They both will give you a homonymous hemianopsia. But if you have an afferent pupillary defect on the other side, and I'll bring that up why later, you know it's the tract if you have an APD. If you have no APD and a homonymous hemianopsia, you know it's the optic radiations. So that's how you can tell, where the lesion is at.
Thanks, Carlo.
So is that, you're welcome, Greg.
Yeah.
Did I answer that okay? I mean,
Oh, no, yeah, beautifully.
Okay. All right. So I just wanted to make sure I answered your question there. So thank you. And then don't forget, you see the two bumps on the chin of Mickey Mouse of the midbrain. The two bumps are your superior and your inferior colliculi. And, those are important. Superior colliculi are important for basically, vision, and the inferior colliculi are important for hearing. So we'll talk about that coming up. So I'm happy that we kind of went over this so that we set up the rest of the lecture. Now, once you go to the occipital lobe, the visual cortex, I want you to understand, and you already know this, that you now have a different stream. Once you process what you're seeing in your environment, there is a dorsal stream, which is the where, that will go to the parietal lobe to say, where is something in space? And you have a ventral stream that will go to the temporal lobe. And that is, what am I seeing? Now, for those of you that know Alzheimer's disease or Alzheimer's disease pretty well, you know that it affects the dorsal stream first, and that is the where something is. So where and what? And you remember there are 20 types of ganglion cells, 20 different types, but we categorize them mainly into two big ones. You have a type of ganglion cell that's a midget, and that will be basically your parvocellular. And then you have a different type of ganglion cell that's for your side vision, that's your magnocellular. So magnocellular are going to end up in the parietal lobe where something is, and we just said the rest there. So we've got the understanding of once it's processed in the visual cortex, V1, where does it go next? And that's where it goes. Now, this is what Greg had talked about earlier and asked about earlier, and I'm glad that he did. There are a lot of pathways here, but remember, the visual pathway is the one that I talked to you. We're going to go from the optic nerve through the chiasm and then upward to the lateral geniculate body. And then it will swing around, and it's called Meyer's loop, and head back to the occipital cortex. That's about 85 to 90% of all ganglion cells, will go that route. I want to make one other comment to you before we move on. It's a very important one. You know, there are ganglion cells. We have about 1.1 million, 1.2 million ganglion cells. And I told you there are midget cells, and there are for the parvo, and then there are ganglion cells for the magnocellular. But of those let's say million, how many there are ganglion cells, 3,000 of those ganglion cells are photoreceptors. 3,000 are photoreceptors. And they are not going to necessarily go this way. They are going to go with the optic nerve, those photoreceptors, not the rods and cones, but the ganglion cells that are photoreceptors. They're going to set your circadian rhythm. And so they're going to follow the optic nerve, chiasm, and tract. But instead of going to the thalamus, the lateral geniculate body, like the visual pathway does, these 3,000 ganglion cells that are photoreceptors, they're going to go to the hypothalamus, the suprachiasmatic nucleus of the hypothalamus. And then they're going to go down your cord and up to the pineal gland to secrete melatonin. So that's how your eyes set your circadian rhythm. That's why cataract surgery throws that off. Not cataract surgery itself. Cataract puts it back. Cataracts throw off the circadian rhythm because of the retino-hypothalamic tract. So we got these different tracts to deal with, but I want you to mainly focus, everyone, not on the retino-hypothalamic, but on that visual pathway that I mentioned earlier. And on the right, if you ever want to go back and listen to this, or email me, I'll send you the slide. These are the 4 pathways that we stress. The visual pathway, 85 to 90%. The pupillary pathway, I didn't talk to you about. The accommodative pathway, I didn't talk to you about, but I did mention the retino-hypothalamic pathway. That's why, because cataracts we deal with every day, the longer the patient has a cataract, the more their circadian rhythm is off. It's called free running. So I just wanted to make note of that. All right. Now,
Hey, Carlo,
yes.
before you move on,
Yes.
just to kind of, connect the dots and say it maybe again, or maybe in a different way. When we look at an OCT and we're looking at that ganglion cell complex, where those ganglion cells are kind of building up just right there in that parafoveal area, and we have that axon coming off, it's that axon that you're talking about that forms the optic nerve, goes through the chiasms, going through that tract and going that lateral geniculate body. That ganglion cell that we're looking at is right there, but that axon is super long.
That's right.
Right. And that's what you're saying. It takes a lot of mitochondria, a lot of keeping that alive, so on and so forth.
That's right. That's exactly right. I mean, this, it's so interesting, Greg. And also, you bring up another good point. Inside because there's 1.2 million ganglion cells roughly, each nerve, each one of those 1.2, you have a railroad system in there, right? You have a railroad system, and nutrients have to go this way, anterior grade, and nutrients have to go this way, retrograde. And that railroad system, has to have, it's called kinesin and dynein. They have to go back and forth. They carry the nutrients like on a railroad track. And, when we talk, Joe and you talk about glaucoma a lot, what happens is not only do you need a lot of mitochondria to keep that axon alive, but you also have that railroad system that has to be formed properly to send retrograde and anterior grade kinesin and dynein to work well as on a regular basis. So when we look at this, I just want to make one other point. If you look at glaucoma from a histological standpoint, you got a lot of buildup of tau and amyloid. You got a ton of tau and amyloid. It's an optic neuropathy, but it's a form of Alzheimer. If we want to slow down some glaucoma, if you look at it from if you could find out how to eliminate the tau and the amyloid, we would do a lot better as well. But you are 100% right, Greg. Look how long that axon is. It takes a lot of mitochondria and energy to keep it alive. So, it's important that we look at it that way. And also, you'll see today, when I look at the next slide, I want to show you something. Here's a sagittal view, and I apologize I'm going over this anatomy, but I want everyone to understand that if I just throw out a name, it may not make sense if you're not familiar, with the anatomy of it. And I know most of you are, but I want to look at this sagittal view real quick, everyone. You see your corpus callosum, right? So the corpus callosum is connecting one hemisphere to the other. So here's your corpus callosum. And I want you to know there are three types of fibers in the brain, very general. You have callosal fibers that connect right to left, left to right, callosal fibers. Then you have association fibers, everyone. Association fibers will take fibers on the same side of the brain, go from frontal lobe to occipital lobe. I'm making that up. Occipital lobe to frontal lobe. Those are association fibers. And then you have projection fibers. Projection fibers go downward and upward. So once again, callosal fibers, okay? And then, you've got these big, let's say, anatomical structures like this. You see, corpus callosum would be a callosal fiber. Now, I want to show you something else here. Here's your midbrain, Mickey Mouse. Here's your pons, and here's your medulla. That being said, we already went over midbrain, okay? And I told you, coming out of the midbrain's cranial nerve 3, and here's your superior colliculus, here's your inferior colliculus, here's your pineal gland, the secrete melatonin from the retinohypothalamic tract coming down and then back up. But here's what I really want to show you. We want to know this anatomy here. Here's your cerebellum, okay? And the cerebellum is connected to the midbrain, the pons, and the medulla through the peduncles. So the cerebellum is connected to the midbrain through the superior peduncle, the middle peduncle, and the inferior peduncle. So the cerebellum is for balance and some other things. But here's the main thing. Look at this right here. Here's your lateral ventricle in here. And here's your third ventricle right here. The third ventricle is going to then go into the cerebral aqueduct into your fourth ventricle. Very important here. So your third ventricle's boundaries, everyone, for today's lecture, you see the third ventricle, here's the thalamus, here's the hypothalamus, both of them encompass the third ventricle. So it goes from lateral ventricle, cerebrospinal fluid will go into the intraventricular foramen of Monroe, into the third ventricle, into the cerebral aqueduct, into the fourth ventricle, and then around the brain, spinal cord, cerebellum, and so forth. So I wanted to keep this in mind, but remember, cranial nerve 3 is exiting in this area here, in the midbrain, and then the rest we'll talk about later. So lateral ventricle and so forth. And what else is important here? One final thing before I move on, because I don't want to spend too much time, but please remember that when we look at this cerebellum plays a large role in eye movements, in coordination and so forth. It's called the hindbrain, but it's called the little brain as well, but it's very, very important for what we do on a daily basis, even though we don't stress it that much. And here's the other thing I wanted to show you for today's lecture. You see the lateral ventricles? The lateral ventricles are here. Really, isn't it interesting? We don't call it ventricle 1 and 2. We just call it lateral ventricles, but it's lateral ventricle 1, lateral ventricle 2. Here's the third ventricle, and then here's the fourth ventricle. No different than here. Lateral ventricle, third ventricle, fourth ventricle. And we need that ventricle system, everyone, to produce the cerebrospinal fluid. We need it so that the brain can float, let's say in a watery substance. You put something in water, it tends to float and be less, let's say, heavy. So it's very important for many reasons. So we want to remember the ventricular system. And then finally, how does that cerebrospinal fluid and the blood of the head drain? It drains through the venous sinuses. So the cerebrospinal fluid, everyone, and the blood of the head will drain mainly into the superior sagittal sinus and the inferior sagittal sinus, and then into the straight sinus, into the confluence of the sinuses, then into the sigmoid, and then into your jugulars. Now, why is that important? I'm going to tell you, if you have a female that takes a birth control pill, and you have that same female who might be obese, who might have a factor V gene clotting mutation, who doesn't exercise, and who smokes, if this superior sagittal sinus or any of these sinuses get a blood clot, you will have the exact same symptoms and the exact same signs as a pseudotumor cerebri patient. But it's not pseudotumor cerebri. It is, to an extent, it's a venous sinus blood clot or venous sinus thrombosis. We'll talk about that later. But I wanted to put this up for you to understand that most of the cerebrospinal fluid and blood of the brain will drain through these venous sinuses. All right, so next up, what study should you order if, don't get me wrong, here in Philadelphia, I got 9 neuro ophthalmologists every block. So I don't necessarily play hero all the time. So I don't want you to think I want you to play hero. But if you are going to order your tests or you feel you're comfortable enough, what tests should be used? MRI is big. CT can be used at times. Don't forget about the MRA if you suspect aneurysm and things like that. And then look at the bottom one, MRV, venography. MRV would be used here for the venous sinuses. And we'll talk about that as the lecture progresses. All right, now, the thing that I want you to understand as we're going to go into cancer. And we're going to talk about cancer and how it relates to the optometric findings in the brain. So we know that the better term to use is neoplasm, and the better term to use, obviously, is /tumor. If the tumor is benign, we don't tend to call it cancer. You just say tumor/neoplasm. If the tumor/neoplasm is malignant, that's when you apply the term cancer. So tonight, I want to differentiate that. If I say tumor, neoplasm, mainly I'm going to say, it's benign. If I say cancer, it's malignant, just so that once again, we're on the same page. Now, what we're going to focus on, everyone, is you see here, brain tumor. And I'm going to show you a couple of these that you might find interesting. And, you're going to see them in practice. These tumors are better identified as intracranial neoplasms. I just told you that. Some of them do not occur from brain tissue itself. Like a meningioma is not brain tumor. It is considered a brain tumor, but it's not from the brain itself. It's from the meninges that cover the brain. So intracranial neoplasm is the better term. However, for most lesions, the clinical presentation, diagnostic approach, and initial treatment are very similar, whether they're on the brain or in the brain. So let's look at the first case. You'll find this interesting. These are the cases that come through here. And, everyone on here tonight has seen something like this. So here's a 77-year-old man with a 3-week history of blurred vision in his right eye. Now look at the next statement. It's when he reads, so I guess looking from left to right, and he also has a right-sided weakness. So we know if he has a right-sided weakness, the corticospinal tract starts on the opposite side of the body. So to move your arms and your legs on your right side, it starts on the left side of your brain, goes down through the brainstem, and then goes to the other side. So right now, he's got a right-sided weakness. So I'm thinking something's wrong with the left side of his brain, possibly. Now look at the APD. He's got a relative afferent pupillary defect in the right eye. And he has a right homonymous hemianopsia, denser above than below. He's got high blood pressure and a pipe smoker. Now let's put all the pieces of the puzzle together, and I'll go somewhat slow with this. So let's take a look. Here is the right homonymous hemianopsia. You see, if you use the grayscale, it looks like a quadrantenopsia, but we're not using the grayscale. We're going to use the pattern deviation. We're going to say that it's a right homonymous hemianopsia. And we're going to say it's denser above than below. And I want you to notice something here. It's very subtle. It's very, very subtle. But if you want to cheat to see if you have an APD, look at the mean deviation. If you take the mean deviation here of 13 and the mean deviation here of 11, just subtract the two, you come out with about 2, and you always divide by 10. And that comes out to be about a 0.2. So a 0.2 or 0.3, anything around a 0.2 or 0.3 is a grade 1 APD. And every 3 points after that's a grade 2, and then another 3 is a grade 3, and then another 3 is a grade 4. That's how the students cheat, right? They look at the mean deviation on a field that's reliable, and then they figure it out by using that calculation. But anyhow, he's got a right homonymous, which is localizing somewhere in the left side of the brain as well, and he's got a right defect with his motor and sensory. And here's his optic nerves. If you look carefully here, this is the same patient. Now I'm going to go back, everyone. Look at what I said. Right-sided weakness, which is the left brain. APD in the right eye, which would also be a left tract lesion. Left tract lesion equals right APD. He's got a right homonymous hemianopsia, left side of the brain. So I'm figuring this is on the left side of the brain. And he's got right-sided weakness. Remember Mickey Mouse's ears? What goes through Mickey Mouse's ears? The corticospinal tract. So I'm figuring since the tract hugs the crus cerebri of the midbrain, there's something going on near that area. So when we look at this, he's got a bow tie atrophy in the middle. You see nasally and temporally, and he's got this temporal pallor here. This is hallmark of a tract lesion. So when I say tract lesion from the chiasm to the lateral geniculate body, hallmark lesion of something, it's not acute because there's no swelling. It must be something growing there. Pallor, this is the typical tract lesion appearance. Bow tie in the opposite eye, temporal pallor in the ipsilateral eye. And this is why. Okay, so if you look above, or I'm sorry, below, if you're looking below the patient, here's the right nerve and so forth. If you lesion the left tract, everybody, you see the nasal fibers cross. And where you see the color here, you can see why you get the bow tie, because you lose nasal and temporal both. So temporal on this eye, nasal here to get the bow tie, and you lose temporal totally in the ipsilateral eye. That's why you get the band, or let's say ipsilateral pallor. So this is hallmark of a tract lesion. And when you look at the MRI, okay, MRI, you see this is a T2, and I'll go over that in a second, but look carefully. Here's a coronal view. We're looking straight at the patient. You see you got gray matter and then white matter, okay? Now look, you see Mickey Mouse again, everyone? You know the cut is at the midbrain. If you look first at the coronal cut, you see there's no gray and white matter. This man has a temporal lobe tumor. And because of his age, we were thinking it's a glioblastoma multiforme and astrocytoma. That's what it was. It's really not called multiforme anymore. It's just a glioblastoma. It's a grade 4 astrocytoma. But look here, everyone. This is looking underneath. So the right side is here, the left side is here. And you can see Mickey Mouse's ears are here. Here's his mouth. And look at the tumor. You can see where I'm outlining. You see how the tumor is compressing Mickey's ears. And that's why it's hitting the corticospinal tracts and why he's having trouble with motor and sensory. So it all makes sense. The tract, the optic tract goes around it. It's hitting the tract. The APD is always in the opposite eye because more fibers have crossed. So that's why the APD on a tract lesion is in the opposite eye. And you can see here, once again, the corticospinal tract to move his arms and legs is a cross tract. So it all makes sense. And I just wanted to show you here, there's the tumor, and we boxed it off for you. The optic tract is hidden here because the tumor is there. And this is
Carlo,
exactly,
go back a slide or two.
Sure.
Because I'm building a lecture after listening to you and Len Mesner and Joe and all these guys. Go back one more, please.
Sure.
And showing how the ganglion cell complex is affected. And this would be kind of neat on on an OCT, kind of showing in this, in the right eye that the full ganglion cell would be affected. And then on the left side, only kind of that temporal side. So you kind of we're starting to get with these instruments with OCTs being able to pick up, bitemporal hemianopia, binasal ganglion cell dropout, with pituitary glands. And, so we always think ganglion cell complex for glaucoma. Some of these neurogenic conditions out there can create ganglion cell loss. So that's just kind of a cool slide right there.
Yeah, and it's a good point, because just like you said, you're going to get a different, I think, reading in one eye versus the other. Correct. Yeah. Okay, so we'll go through this, and this is exactly what happened to this man. So you can see the right eye's on the right, the left eye's on the left. This was where you see this, let's say, lightning bolt, that's the optic nerve. But the tract is where his tumor was. And that tract lesion, you get the APD in the other eye, you get the homonymous hemianopsia, and you get the corticospinal tracts hurt. So it all fit perfectly. And I just wanted to show it to you again, and I'm sorry for rehashing this so much, but I think it's kind of interesting. Look at Mickey Mouse again. Look how wonderful you can see this. Here's the tract and how it hugs the crus cerebri, where your corticospinal tracts are. Look at the red nucleus. And look at this, everyone. You see substantia nigra, right? If you don't have enough substantia nigra in the midbrain, you are Parkinson's. If you've got too much, you're schizophrenic, right? So all of this is in the midbrain, and cranial nerve 3 is leaving right here in the interpeduncular fossa. So all of this anatomy is important. And then you got your cerebral arteries, your middle cerebral, and everything that's here. Mammillary bodies have been cut, chiasm. It's really good view here. Now, this is just another sagittal view, everyone, to show you how the tract hugs the midbrain. Once again, and then goes upward to the lateral geniculate body, and then out to the occipital cortex. So it's just a sagittal view. Very important here. The other thing is this. You see the crus cerebri that I'm talking about? This is the corticospinal tract to move your arms and legs. This is why this man was losing sensation.
I'll be back.
You see here, and then you see the corticospinal tract comes down, goes through the midbrain, the pons, the medulla, and then goes to the other side. So that's why it's a problem when you have a lesion there. And then the other thing I just wanted to show you, everyone, don't forget this. You have to have an ascending tract for pain and temperature. You got to feel as well. And that is also going upward through the crus cerebri. So that's why this man had motor problem and sensory problem. And so I just want to reiterate this one more time. To move your arms and leg is the corticospinal tract. To feel something, pain and temperature, is the what's called spinothalamic tract. Both of those go through the crus cerebri. That's why this man is having problems. Now, I want to then move on, so we have a little bit of time showing some other things here. This individual had surgery for the glioblastoma. He had chemo and some things you can see here, and then he died about 7 months later. Most people with the glioblastoma multiforme live about maximum 12 months, maybe 15. So we got to catch them earlier. And it's tough to do that. But what's interesting about, they're called butterfly gliomas because it's an astrocyte, a glial cell. What happens with glioblastoma multiforme is you can see here, it's a butterfly lesion. It goes into one hemisphere, then it goes into the other hemisphere. And that's why they're very hard to dissect or resect. But it's a grade 4 astrocytoma. And I'm going to show you another type of cytoma, astrocytoma here. Now we're sticking with brain tumors. I just did grade 4 astrocytoma. I'm going to show you grade 2 now. It's an astrocytoma. But what's interesting is, do you see the case I just showed you? This man did not have swelling. The first case, the 77-year-old, he did not have swelling of the optic nerves. He had pallor, bow tie, and then sector temporal pallor. But look at this kid. This boy comes in for a routine exam. He ends up with the diagnosis is a left temporal lobe astrocytoma. You can see the swollen optic nerves. And here it is. Look at the picture on the right. You see Mickey Mouse again, Mickey Mouse midbrain. You see the crus cerebri is pushed in. So the edema from this astrocytoma is pushing the corticospinal tract and the spinothalamic tract, he's going to, within days to months, he's going to start losing motor and sensory. You can see that. And his tract is going to be affected. So he's going to have an APD in the other eye. But look at the size of this. Look what it did to the ventricles, the lateral ventricles up here. It actually squeezed them. The third ventricle is squeezed. The lateral ventricles down here in the temporal lobes are obliterated. So that's why the cerebrospinal fluid can't flow properly and you get this appearance. Now, this boy is still living. And what I wanted to show you was this. The astrocytes, just like in the retina, the astrocytes, they're glial, right? Glial is Latin for glue. So astrocytomas are big in the sense of what neurosurgeons have to deal with, but also with ophthalmology, optometry. And what I've tried to show you, here's the 4 astrocytomas. I showed you number 4 first, glioblastoma. It's the most aggressive. But what I just showed you was what this boy had. You see this boy here? This boy has a fibrillary. Even though he's 16, his is a grade 2 astrocytoma. So pilocytic astrocytomas, they tend to live a lot longer. Fibrillary, they live about 20 years. Anaplastic, a grade 3, maybe live 10 to 15. And glioblastoma, the butterfly-shaped lesion, is about 12 to 15 months. So as you go in the grading system, the more the grade, the higher the grade, the less chance to live, or the less time to live. So look at this question here. Astrocytomas comprise 80% of all central nervous system tumors, right? That's what the optometrist / ophthalmologist is going to see. And look at the brain tumor suspicion. Patients with primary brain tumors or metastatic brain tumors, let's say from breast cancer, they only have a headache at the time of the diagnosis 30% of the time. Brain tumors are usually worse in the morning with nausea and vomiting 20% of the time. Headache will eventually be there at 70%. But I'm going to tell you something. Remember this. These patients who have these tumors, specifically the glioblastoma, they present initially more than likely with a seizure. Ted Kennedy had a seizure, then they diagnosed it. John McCain, seizure. Biden's son, they all had glioblastoma, right? The president's son died of glioblastoma. John McCain died, and so forth. So seizure is usually first, not necessarily headache or nausea or vomiting or swollen optic nerves or a feeling of ill will. They're not feeling well. So keep that in mind. And look at this here, everyone. Brain tumors in general, 50% are primary, like an astrocytoma, and 50% are metastatic from somewhere else. Women, breast. Men, prostate, bone, lung, colon. All right, so metastatic lesions equal primary brain tumors. It's not one more than the other, unless you're a child. If you're under the age of, let's say, 10, maybe 12, maybe pushing it 14, maybe 15, most of the children will only have primary brain tumors. Very rarely do they have metastatic brain tumors, but it still can occur. So keep that in mind. Let's look at the next tumor. The next one's interesting. 5 years ago, this young 25-year-old had a cup to disc ratio of 30/30. And remember, it's not just about the cup to disc ratio. You have to define the nerve. Cup to disc ratio is nothing. You got to define the nerve. It's no swelling. It's well perfused. The margins are distinct. It's tilted. It's flat. Whatever it is, that's probably more important at times. But here, there was no pallor, and she had a 3/3 cup to disc ratio from an outside optometrist. 3 years ago, the CD ratio, as time went on, started to increase, and she came to us. I didn't see her at that time, but because of the increased CD ratio, they decided for some reason to get an MRI of the brain and orbits, the second doctor who saw her, and they said with or without contrast, they said everything was fine, okay? Then when I see her years later, this is what I get. She's got an intraocular pressure of 25, and you see well perfused, flat, margins are distinct. You can talk about peripapillary atrophy, alpha, beta, and gamma zones. You can talk about how deep the cupping is, things like that. But look over here, everyone. You see the pallor. So I'm saying, hey, this is not right. And I just got to say this, and I find this interesting. Why we're in 2021, we're still calling it glaucoma, I don't know. It's not an oma. I don't know why we just don't call it some type of optic neuropathy. Joe, look into that for me, okay? I don't know why we're calling it glaucoma in 2021. But what's interesting here.
Actually, Carlo, I don't call it glaucoma. I call it a cranial nerve 2 palsy.
There you go. That's probably one of the best definitions I've heard in a while. That's exactly right. And you see the pallor. So something else is going on. She could have glaucoma, but something else is going on. So when you look at the mean deviation, take the 2 and subtract them. That's 10. Always divide by 10. That's a 1.0. That puts you somewhere at about a grade 4 relative afferent pupillary defect in that eye with the higher mean deviation. Then here's her MRI. If you look at her MRI, what do you see? You see on the sagittal view. Now let's take a step back what we talked about before, everyone. Here's the corpus callosum, colossal fibers, right to left. Look at this right here, everyone. Thalamus. Look at midbrain, superior colliculus, inferior colliculus. Look at the pons, look at the medulla, and here's your ventricular system, lateral ventricle, third ventricle, fourth ventricle. But look at this tumor here, this pituitary adenoma pushing unequally at the chiasm. See here, unequal. And I want to make one other note to you, everyone. Please look at this. Sometimes some of you are really good at this, but you see the ventricular system, how it's dark? People always think this is a T1 because there's no cerebrospinal fluid. But here's the better way to figure out if you got a T1 or a T2. You see this typical here? You see this typical gray matter? Gray is always darker. That's the cell bodies. And then the axons are white. If the gray matter fits this way, gray matter darker, and the axons white, you always have a T1, always. So don't get fooled with the ventricular system lighting up or not. This is a typical pattern. Gray is darker than white. You got a T1. T1s are mainly used for anatomy. T2s are mainly used to find pathology, even though they can be intertwined. So here you have a T1. You'd have to look up here as well to see if you have a T1 versus T2 MRI. So what I wanted to show you here is you see pituitary tumors cannot grow downward because you have the sphenoid bone. So they have to grow upward or out. And remember, this is the cavernous sinus that surrounds it. And here's your cranial nerves. So what tends to happen is if you see this infundibular stalk, the chiasm is 10 millimeters above it. On autopsy, many people have microadenomas, less than 10 millimeters. It won't hit the visual system, so we don't know they're there. But if it's a macroadenoma, more than 10 millimeters, it's going to grow upward more than likely and hit the chiasm. And so those are the ones that we tend to experience. And here's another one, right? Here's your typical, here's the ventricular system. It's hard to see gray and white. More than likely, this is a T1. But you can see in this particular, this right here is a pituitary adenoma, your typical bitemporal defect, right? And this one was treated with, this one was treated with radiation, excuse me, bromocryptine. This was bromocryptine. And then this one was through surgery. All right, so different, we did astrocytoma grade 4, and now we're looking at these here. Now look at this one. Here's another pituitary tumor. Look how large this one is. And when you look again, here's Mickey Mouse. So we know the cut is through the midbrain. And once again, thalamus, midbrain, pons, medulla, corpus callosum. Here's the fornix that I told you goes to the mammillary body for memory. And look at the size of this macroadenoma. Okay, and this one was transsphenoidally taken out. So they happen, and these are macroadenomas. Now, my final comment on this, and You want to do the poll first, Greg, or you want me to make the comment?
Well, we got to kind of do some live and interactive here. So
Go ahead.
I think we might have missed this one here. So I'll let this one go, and then we'll let you kind of get rolling here. And then while this is rolling here, Carlo.
Yep.
Someone asked way back when you were talking about the retinohypothalamic pathway.
Yes.
What level of cataract will interfere with that? Is it more the cataract? My question to add on to it, they have NS2, 20/40 vision. Is it the brunescence and the yellow and filtering out the blue? What are we looking for to interfere with that pathway?
Yeah, that's a good question. In the retinohypothalamic tract, those 3,000 ganglion cells that are photoreceptors that use melanopsin as their photopigment, anything that starts to any brunescence, NS1 will start to alter what's going on. NS1, cortical spoking, posterior subcapsular. And then what happens, everyone, that retinohypothalamic tract, remember it's going to the suprachiasmatic nucleus and then down to the cord and then up to the pineal gland to secrete melatonin. Even the slightest amount of that disruption will give you what's called a free runner / chrono disruption. And all of your cells have a circadian clock of when to secrete what hormone. And that's why older people who have cataracts, 2025, 2030, 2040, 2050, that's why they can't sleep at night. That's one of the reasons why, because their whole circadian rhythm is screwed up. And so it's very interesting. Diseases like glaucoma that wipe out those ganglion cells, diseases that for some reason, like, toxo scar, even though that's deeper in the retina, anything that wipes out that ganglion cell. Greg made a comment earlier that was important about doing the OCT. In diabetes, everyone, we only call it diabetic retinopathy because we see the hemorrhages, exudate, cotton wool spot, and edema. The neurodegeneration occurs 2 to 3 years earlier. You're going to lose a ton of neurons before you get any visible retinopathy. I don't know why we're not doing ganglion cell, counts early on in the disease, because you always get the neurodegeneration first. Then you get the microangiopathy that we see. It's the same thing. So if you're losing it from diabetes, hypertension, glaucoma, you're losing it from some type of other pathology, that retinohypothalamic tract will be altered. And that person, they think that that's responsible partially for Alzheimer's disease. They think the retinohypothalamic tract is responsible for insomnia, people who can't sleep well, people who have anxiety, people who have, other conditions that deal with memory. So it's very important that I tell the student all the time, I hope our surgeon takes this lens out, because you're going to put the circadian rhythm back with that new lens like they were when they were born. So that tract is extremely important.
There's a question, Carlo, regarding, can you review the, subtracting the mean deviation and grading the APD? And then what I would make the comment on the one that you had was, and you had it in there, but the echo, when you had your 13 and your 11, it was 2 difference, that would be small or trace, or, you'd have to look hard to see that one, because it's about a 2 or 3 where you can really start seeing them. But if someone asked that question, if you want to go over that.
Sure. You take the mean deviation of one eye and you subtract it from the mean deviation of the other eye, and you always divide that number by 10. You can start to see an APD at about a 0.3, maybe a 0.2. And anything up to a 0.3 is a grade 1 APD. From a 0.4, 5, or 6 is a grade 2 APD. A 0.7, 8, or 9 is a grade 3 APD. And anything greater than a 0.9 is a grade 4 APD. It's just one way to do it if you don't have a neutral density filter to put on the other eye and try to figure it out.
And we all treat glaucoma out there. And that glaucoma is most of the time asymmetric. And you'll get in a glaucoma patient maybe a -10 on a mean deviation, which is a severe visual field defect. You might only have a 3 or a 4 in the other eye. The eye that is the bigger number, the 10, should have the APD that's in it.
Yeah, the one with the bigger, that's correct. The one with the larger mean deviation. Yep.
I'm going to do one more poll here, Carlos, so we can get caught up.
Sure.
you can keep chatting here and you can talk, but I'll let the poll kind of run.
Yeah, there was a question that, what about if you have insomnia and should you go get cataract surgery? I mean, obviously I can't answer that. There's more to it than that. But what I'm saying is that the intensity of the cataract, or just the cataract itself, may help with that. I don't know what other conditions would be going on. Obviously, each case is different. But if you look at the research, that retinohypothalamic tract is so important to overall health that I could give you 9 things if you want what it does, but you need to have that circadian rhythm set properly. And what ends up happening is, if it's not set properly and cortisol gets released at the wrong time and for too long from your adrenal glands, you can have an increase in blood pressure. You might not sleep well. You may end up with hippocampal loss for memory. You may end up with diabetes by insulin resistance. It can be a mess. So cataract surgery really does have a systemic benefit more than just vision.
And we'll go over these poll results here. Carlo, you had in here, what is the most common lesion found that produces a bitemporal hemianopsia? Pituitary adenoma, we got 98% of the audience. And then, the first fun question that we did earlier was white or red. And I think it was just a little bit of red wine versus the white wine. Maybe it was, I think, 52 to 48. And here, it's my first webinar, 17. So 16%, 2 to 3 is 33, and frequent flyer is about 51. So no matter what your first, second, or third, or frequent flyer, thank you here tonight. And you can see we're all about education, and Carlo is certainly doing a great job of that. So, all right, Carl, I think we're caught up on the polling questions. So.
Sure. And Dr. Visco asks, so what are your thoughts on blue blocking lenses? I can talk to you about that later, if that's okay, just for time, if that's all right. All right. So real quick, pituitary adenoma is the #1, cause of bitemporal. We already said that. It doesn't always have to be a pituitary. It could be a craniopharyngioma. That's a remnant of Rathke's pouch in that area. Meningiomas are mainly women, and gliomas, we went over it. And then don't forget, arachnoid cysts play a big role. So, or not a big role, a small role, I should say. So all of these things can cause bitemporal. Now let's go into meningioma. Let's go into a meningioma, mainly women. And what I wanted to show you here, this particular patient showed up first time with us, and she said, I need an exam. And you can see that this is her right eye. See how pale it is? That might even be an optociliary shunt vessel. I'm not sure. But anyhow, it's pale. And then let's take a look. You've got your cut here because you're at Mickey Mouse. You're at your midbrain. You can see the meningioma here. I'm going to tell you it's a meningioma. And you can see, once again, this is probably a T1, but you can see the meningioma is wrapped around the carotid system in the cavernous sinus. And so they had a really difficult time here removing this surgically, but that's what they did. So what I'm trying to show you here, everyone, is that meningiomas do occur. You can see they're tumors comprised from the cells of the arachnoid layer of the meninges, not the dura, and not the pia, but the arachnoid. And these neoplastic proliferations grow slowly in the subarachnoid space. 3-to-1 ratio of female to male, commonly 30 to 50 years of age, but meningiomas are rare in patients less than 20. So meningiomas do occur in the optometric practice. You got a pale nerve here. Remember, they can go transsphenoidally, or if it's a type of prolactin secreting tumor, they can go bromocryptine orally. So I'm not going to go into this too much, but you can see most meningiomas compress the optic nerve by extrinsic factors. They are unilateral, MRI, CT, and then they'll either observe them, surgically remove them, radiation, and so forth. So just keep that in mind, everyone. It's a common thing that we may see. All right, let's look at the next tumor. Okay, 69-year-old African-American male. Now, you see all these tumors we talked about, grade, right? Okay, we've talked about all of these up to this point. They're all solid tumors. Now we're going to look at something that is a solid tumor, but may not be. An African-American male presents for the emergency service with acute red eyes, right eye more than left, and itching. Somebody diagnosed him with acute allergic conjunctivitis and treated with Pataday. Okay, so I'm going to show you here. Look at this here. Presented to the emergency service. The day he comes in, mucus discharge occasionally, mild headache, and he's got a cotton ball in his right ear because he feels like an earache is coming on. And he's got hypertension, non-Hodgkin's lymphoma, he says is in remission, and he's got sinus polyps. Now take a look here. Upon straight ahead view, when I saw him, you can see he's got this edema of the upper lid, but you can notice that the tarsal plate is still intact, right? That's a good sign to an extent. And he's got this, let's say, sectorial, it's really red all over, but more temporally. So that's the straight on view. But then when you do EOMs, when you do extraocular muscles, you can see the right eye can't go up. The left eye is okay going down to an extent. He can't get out all the way, and going in is okay to an extent. But you can see he's got some kind of restriction here. Now go back right here. This is what started to scare me, non-Hodgkin's lymphoma. And then when you look down and you take this proptotic view, I could tell, hey, something's not right here. This right eye's out way more than the left. He's a 25 on exophthalmometer versus a 21 with a base of 110. And I started saying to myself, okay, if it's not a lymphoma, what else could it be? And I looked it up, and here's some differentials, right? So he didn't have thyroid. He said it wasn't super hot. It could be any one of these. But anyhow, my main thought was it's this non-Hodgkin's lymphoma coming back. And that's what it was. And what ended up happening was they did blood work. I sent them to Neuro Ophthalmology. They did bun and creatinine before the MRI. It's a large mass located in the right lacrimal gland. He underwent an orbitotomy and biopsy, and it's a B-cell lymphoma that's malignant. And then what I just wanted to show you here is that we have to think about what's called the wet tumors. And the wet tumors are lymphoma and leukemia. That's the other way it will present to the optometrist / ophthalmology, meaning cancer. We talked about the solid tumors. Here's lymphoma. Remember, lymphoma is usually B cells, maybe some T cells, but located in the lymphatic system. And in the eye will present with a vitritis to an extent, and it will present with a choroidopathy. Now, I want to make this comment. I know it's lingo, but I want to make this comment. Vitritis it's a misnomer. Vitritis is a misnomer. There's no such thing as a vitritis, meaning I don't call it an aqueitis. I don't say, hey, I have an aqueitis. The aqueous isn't inflamed. I say I have an iritis or I have a uveitis. It's a misnomer. The vitritis is really either the retina inflamed, the choroid inflamed, or the blood vessels inflamed. So there's no vitritis police officer, but in reality, when you see vitritis, you think one of those. And lymphoma tends to give it the vitritis or let's say the retinitis choroiditis in the posterior pole, along with these leopard spot choroidopathy and so forth. So I just want to make known to you that we have to think of with the wet tumors as well, lymphoma and leukemia. And you can see how the lymphoma can present. You can have this big lymphomatous B cell proliferation in the choroid or maybe outer retina, right? And then it can start to push on the RPE and cause hyperplasia, and you get the leopard spots. So this would be a form of lymphoma. And you can see in this man, it was in his lacrimal gland, not in his retina / vitreous. And here's that leopard spot, choroidopathy, retinopathy, and most lymphomas are of B cell. B cells make antibodies, and they are antigen presenting cells. So lymphoma, we have to think about. And you can see here that it can infiltrate. You can see it in this particular lymphoma. It's infiltrated with the leopard spot, choroidoretinopathy, the vitreous cells, and you can actually see the lymphoma here. Okay, then once again, they'll do chemo, radiation, and so forth to get rid of it. Now, lymphoma is a masquerade syndrome, so be careful. It can present many ways. That's all I want to tell you there. And here's the other one, everyone, leukemia. Leukemia is the other big wet tumor, but this is now the white blood cells, not in the lymphatic system, the lymph nodes or the spleen, but in the blood itself. And lymphoma, I'll tell you what, when you work with surgeons, they got nerves of steel. But if you got a bilateral looking CRVO picture, that scares them because it's not a bilateral CRVO most of the time. It's an actual #1 differential, as you can see here, is leukemia. And there are different forms of leukemia, right? But out of all of them, the leukemias, and there are different forms, there's lymphocytic and myelocytic, but I just want you to know that lymphoma and leukemia are the wet tumors, and they can present as well. All right, let's move on to keep on track here. Let's look now, we get away from brain tumor, let's look at stroke. And it's always like interested me of why they call it a stroke and not a CVA more, right? It's a stroke of lightning. It happens so fast. And with stroke, everyone, we all have stroke patients. You see stroke, 80% of strokes are ischemic. So a blood vessel is broke. 20% of strokes, there's a bleed, intracerebral or subarachnoid. And look at the bottom. This is so interesting. If you have AFib, atrial fibrillation, about 15% of all embolic strokes come from AFib. So if you have atrial fibrillation, please don't smoke. Make sure you get your medicine to put you back into rhythm, because it's a large number to create. It's a large percentage of patients. It can give you an ischemic stroke. Now, take a look at this. The carotid could be affected, or the vertebrobasilar can be affected. But when you look at stroke in general, okay, either one can be affected. So the carotid, the front of the eye or the front of the brain, and the vertebrobasilar, the back, okay? And look at the stroke risks. This is what I said earlier. AFib is huge, 4 to 5 times increase in stroke risk. But look at what else. High blood pressure, diabetes, cholesterol, cigarette smoke. We all know that's the metabolic syndrome. High red blood cell count can do it. Heart disease. 75% of all strokes occur after the age of 65. So that's good. They don't always necessarily occur younger, but when they do, look at this. Stroke in the young. Heroin abusers, the strokes are ischemic. Cocaine, ischemic. And then look at this. Mitral valve prolapse called Barlow's syndrome, a patent foramen ovale, the hole in the heart, right? You got that there? Those increase your risk of stroke. Alcohol use, sickle cell disease. And once again, you can see here a hypercoagulable state. So you're clotting. So strokes do occur in the young as well. You can see all the talc here. You see the talc retinopathy, the talc vasculopathy. They cut the drug with talcum powder. You don't get the full, you don't get the complete drug of what they're buying on the streets. But anyhow, remember the vertebrobasilar system is the posterior system. The internal carotid is the front with the anterior cerebral and the middle cerebral. And what connects the two, everyone, is the circle of Willis, right? That connects the two. So that's just anatomy to show what's going on. And here's the other thing I wanted to show you. Do you see the bend of the internal carotid? Wherever the internal carotid bends, you know you're in the cavernous sinus. And then you see these striate. I mentioned these earlier. Do you remember when I showed you cranial nerve 1 and I said you have a lateral and a medial olfactory striae, and in between are the anterior perforating substance? That's what perforates these blood vessels. And they go to the basal ganglia. And you know the basal ganglia are so important for movement of the eyes and movement of the body. That's why if you have hypertension, you don't have to stroke out the middle cerebral artery. If you stroke out these lentostriate arteries that go through the anterior perforating substance, you can still end up with a hemiplegia. So that's why keeping the blood pressure as close to 120/80 is important. And this is just what I wanted to show you. Take a look at what we just said. Here's your corpus callosum. Here's your ventricle system. Here's your septum pellucidum. Here's your, okay? This is the fornix, it doesn't matter. But you see these here, these basal ganglia? They're really not ganglia, they're nuclei. I don't know why they call them basal ganglia. But you see the caudate right here? And then, you know, caudate, you ever hear of Huntington's chorea? If you mess up your caudate, you're going to get Huntington's chorea. You see here the putamen. The putamen is the outside. How many of you have heard of Wilson's disease with the corneal deposits? That's the putamen, Wilson's disease out here. And then the globus pallidus are in here. And then you have the subthalamic nuclei and substantia nigra. All of these are called basal ganglia. Stroke goes after these, everyone. And why am I telling you this? It's because eye movements, saccades and pursuits go through the basal ganglia before they get to the extraocular muscles. So a stroke that affects these basal ganglia will affect the extraocular muscles. Now, if you're awake for this, I hope, I mean, if you were asleep the whole time, that's fine, but this is what I want you to get, you know, ready for. This is what's interesting. I just want to show you this. You'll like this, and I think you can apply it. You see the cortical stroke versus the brain stem stroke? Okay, now, it doesn't matter, it's going to be diagnosed somewhere. But what's interesting is, you see the homunculus of the brain? The face is down here, and then the hand and the body and the legs go over here. This is the homunculus. So if you stroke out here, you're going to affect your face. You stroke out here, you're going to affect your, you know, torso. Down here, your legs. Okay, that's the motor homunculus and sensory homunculus. But that's not the point. If you see the cortex, if it's very focal stroke, it affects my arm, my leg, my portion of my torso. It's always anterior cerebral, middle cerebral, posterior cerebral, cortical stroke. Fine. But if it's a general stroke, it's going to be the rule of fours, and that's a brainstem stroke. So what you do, what's the rule of four? It's very simple. You see the brainstem? Any cranial nerve that divides into 12 is a midline stroke. So cranial nerve 3 will divide into 12, 4 will divide into 12, 6 will divide into 12, 12 will divide into 12. Those cranial nerves, if they're affected, it's a midline stroke. Make sense? These are focal strokes. Cortical strokes are focal. The leg, the foot, the arm, the hand. Brainstem strokes are motor, you'll see what I mean, and lateral. So what do I mean by this? Okay, so here's what I want to show you. The medial structures, cranial nerve 3, 4, 6, 12, they're going to have something associated with it, a motor pathway problem. They are going to lose conscientious vibration or proprioception. The medial longitudinal fasciculus to move the eyes will be affected, and the motor nerve nucleus will be affected. So the medial M stands for motor problems. 1, 2, 3, 4. The lateral structures over here, the ones that are not 3, 4, and that the lateral cranial nerves that are affected will give you sensory problems. Okay, that's all I wanted to show you there. Not that you need to know it, but that's how they do it. Okay, so do you have a cortical stroke or do you have a brainstem stroke? And brainstem strokes are what I just showed you there, medial, midline. All right, here's the other thing to remember. Amaurosis fugax is not equivalent to a TIA. It is a TIA, but not equivalent to it. And what do I mean by that, everyone? If you have this amaurosis fugax event, your patient does, it has an isolated calculated risk of 2% risk of stroke a year. Amaurosis fugax is an indicator for both coronary and cerebrovascular disease. Now look at this. This is why it's not equivalent to a TIA. Look at the retinal emboli. If you see retinal emboli, the calculated statistical risk for stroke per year is 8%. If the patient has a TIA, and some people will call amaurosis fugax a TIA, and it is, but the TIA as defined in this population is of the arm, the leg, the face, the torso. A TIA has an 8% risk of stroke per year. So there's just some numbers to remember that amaurosis fugax is a TIA, but not equivalent to a TIA in its risk for stroke per year. And the big ones are retinal emboli, be very afraid, and a true TIA, loss of sensation and motor for a while. And then, they're going to do, I'm not going to read these to you, but they're going to do your typical MRI, CT, CTA, MRA, and so forth. And whatever process that you need to do, whether it's a metabolic panel, get the heart checked, urinalysis, chest x-ray, and then we will then deal with the visual defects that may come with it, or cranial nerve palsies or so forth. And then take a look at this. Always, if the patient has had a stroke, or you think recently had a stroke, always check the blood pressure in both arms. If it's different by more than 10 millimeters systemic, the diastolic and systolic, you think subclavian steal syndrome, where you got a blockage and the subclavian artery is stealing the blood. You might need to auscultate if you feel comfortable. If not, just send it out where you need to, and then ask the appropriate questions. So, I'm diagnosing stroke here for you, but I know we do a lot of things post-stroke, but I'm just telling you in the early phases of what's going on. And then we'll move on, and we're almost done. About 3% of stroke patients have a second stroke within 30 days. Recurrent strokes occur in 25% of stroke victims within 5 years, and 35% have a second stroke within 2 years. So it's not you have a stroke and then you're not going to have another one for a while. That's not correct. So just keep in mind these statistics, that they're going to have another stroke probably at some point. And I wanted to show you this because of dementia. We think of dementia because of Alzheimer's disease. There really is no apostrophe S anymore. It's just Alzheimer's disease. But look at the rest. Lewy body disease tends to affect the posterior brain, Lewy body. That's 20% of all dementia. And then look at the other 20%. Multi-infarct mini stroke. It's very big. It doesn't have to cause major problems, but multi-infarct mini stroke, you're going to get dementia at some point if it affects mainly the hippocampus, fornix, mammillary body region. So those are important to keep in mind. And then don't forget this, everyone. There's your typical patterns for stroke. We know it can be a homonymous, as once again, is there an APD? If there's, is it in the tract? If there's an APD, if there's no APD, it's behind the tract in the radiations. We went over all of this. Homonymous hemianopsias. All right, last few diseases here.
Carlo, let's do a polling question to keep it live and interactive.
Yep.
Yeah, we're going to do number 3. Most intraocular lymphoma is of what white blood cell type? And then the fun question is regarding soft drinks, Coke or Pepsi. And then it looks like there's a question, Carlo, if you want to take a look into the
Sure.
chat box.
How about atherosclerosis? I just had a patient who had a good amount of atherosclerosis in his CRA right on top of the optic nerve. Doc, do you mean you saw an embolus? Because if you had that's because there's arteriosclerotic changes, which is the hardening of the artery. Then you have the plaque buildup, which is the atherosclerosis. If it's atherosclerosis and you saw it, then it's a plaque. So it's a plaque. Yeah, so that's an 8%. That would need a heart evaluation, a carotid evaluation, 8% chance of stroke. So yeah, it would be a plaque. That's correct. Or are you saying no plaque, or are you saying no, you didn't?
When you asked the question, if was it an embolus or whatever, he put
Yeah,
no.
it's a
Then
plaque.
yeah,
Yeah.
that's plaque. Yeah.
Yep. So that would be big time problem. That's correct.
All right, I'm gonna end the poll here, Carlo, and share the results. And we have down here is the majority being B cell. And looks like we have Coke as the winner here. Any comments you want to make on that intraocular lymphoma B cell? Any comments on?
No, I was just happy that they got it was B cell. That's good. That's good. All right. So let's finish it up here, the last 20 some slides. You see optic neuritis. So we went from brain tumors to stroke. Now let's look at optic neuritis, everyone. Do you see there are different types? There's retrobulbar, that can be with MS. There's papillitis, that can be with MS. But there's a different type of optic neuritis called perioptic neuritis. And it's really not the optic nerve that's swollen, but actually the meninges to an extent. It's actually meningeal swelling. And that can come from sarcoid, and that can come from syphilis, and it can come from encephalitis. So not every optic neuritis, obviously, is going to be with MS, but we're going to focus on the MS tonight. And so 50% of multiple sclerosis patients get an optic neuritis at some point, 50%. And so probably you as the optometrist are going to see that. We know that multiple sclerosis, so multiple scarring, it's an autoimmune inflammatory cascade. And it attacks, you see the oligodendrocytes, it makes myelin, the central nervous system cannot fight possibly a virus and so forth. So it's gonna be a myelin autoimmune inflammatory attack cascade. White matter dysfunction, loss of eventual myelin. And look at this with multiple sclerosis, everyone. Time and space. So it might occur in the bladder the first time, 5 months later, it occurs with loss of speech. It's a time and space problem. And the risk for multiple sclerosis increases the farther you live away from the equator. So for the first 15 or so years of your life. So the closer to the equator, the less chance of MS. There's a lot of theories for why that is. And then here's the profile. Just wanted to give you a profile so that you can kind of keep this in your clinical knowledge base here. Females more than males, way more for multiple sclerosis, optic neuritis profile. Caucasians, way more than anybody else, but African Americans, more severe prognosis when they get it. Usually between the ages of 15 and 45. And look at the nadir. Nadir, not the apex, but the nadir, the bottom of the vision. It gets worse at about day 5. That's your worst vision, your nadir or nadir, however you want to say it. And then you start to get recovery about 3 weeks to 3 months or so. The fellow eye is involved 20% of the time. So you want to tell your patient there's a chance it can happen 20% in the other eye. And 92% of the patients will have, on an optic neuritis diagnosis, will have pain upon eye movement. And then don't forget about Uthoff's sign, vision deficits with an increase in body temperature. Let's say through a hot bath or exercise, that's Uthoff's sign. And then La Hermite sign or La Hermite sign when you have tingling, let's say down the arms when you flex the neck. La Hermite sign and Uthoff's sign. Those can all go with MS. Now, look at the optic neuritis. It doesn't have to be MS, like I told you. It could be an infection like measles and mumps, chickenpox, mono, zoster. It could be sarcoid and syphilis, or it can be intraocular inflammation, something that staph infection or whatever. Optic neuritis does not have to just be MS. And then take a look at this, everyone. This is the updated McDonald, okay? Not Vanessa. Well, maybe I think it was Vanessa who did this. She updated the diagnostic criteria for multiple sclerosis. That was a little joke there. But you can see here, the 2017 revision is basically looking at the conventional T2 and T1 sequences, and multiple sclerosis lesions can occur anywhere in the central nervous system. It doesn't just have to be in the brain. It can be in the cervical cord, the thoracic cord, the lumbar cord. It can be anywhere. So MS lesions don't have to be just brain, which we know are paraventricular, around the ventricles. So once again, you see in this picture, here's the ventricle system. You see the hot spots here, the demyelinating events, the inflammation, they're paraventricular. And what I just wanted to show you here is that if your patient comes back with no lesions after the optic neuritis, everyone, you have a 16% chance of MS within 5 years. 1 to 2 lesions, 37%, 3 or more lesions. From the optic neuritis treatment trial, 51%. So the more lesions they have, you see this person here, let's say there's one lesion here, one lesion here. This might be a lesion, I'm not sure. Let's say there's 2 lesions. So 37% chance risk. And then what are they going to do for them? 3 days of IV methylprednisolone, 11 days of oral pred. And then they're going to, through the CHAMP study, everyone, they're going to give them interferon. They're going to give them Avonex interferon or some other type of interferon. But look at this. You see interferon therapy? It's used not only for MS, but it's used for hepatitis B and C. See what they're called? Beta-seron and Avonex and so forth. Copaxone's not an actual interferon. It's another immunomodulating drug. But what I wanted to show you, please, everyone, keep an eye on this. You see the beta-serons and Avonex? If anybody is going on interferon for MS or any other treatment for hepatitis B or C, you need to do a preliminary eye exam. Take photos if you have to. If they have interferon retinopathy, you see what happens here? It looks like diabetic retinopathy a few weeks after the interferon has been, injected or taken. So you can see here, this person had hepatitis and was B, I think, I can't remember, B or C. Here's the initial photos. And then 2 weeks after the starting of the interferon, you can see all these cotton wool spots occurring. And what we did for this patient, I said to the doctor, I said, look, it's not affecting the optic nerve. It's not affecting the macula, the fovea. I said, please leave him on it. We'll watch him closely. But the doctor and the patient had a conversation. And even though the patient had hepatitis B or C, I can't remember which one, they took them off of the interferon because of this retinopathy. But I think that's a mistake. Okay, there's no macular edema, there's no optic nerve, he's 20/20, there's no hemorrhaging, but they decided to go off of it. But the point is, do a preliminary exam and then see him back in 2 weeks after the interferon. Some people say 4, it's up to you to check for how it's progressing. And then, is optic neuritis really MS? Maybe it is. But look at this, they put this in categories now. So MS is a lifelong disease with walking issues, balance from the cerebellum, corticospinal tract, the bladder, vision loss, optic neuritis. There are 3 main types of MS: relapsing, primary progressive, and secondary progressive. Okay, but there's this disorder right here, clinically isolated syndrome. The patient gets a single episode and that's it. Women between the ages of 20 and 40 have a higher risk of getting clinically isolated syndrome. So when you get the letter back now, in the letters that I get back from Wills, the neurology department or the neuro ophthalmology department, they always mention clinically isolated syndrome. They think it's this, not MS. Is it a variant? Not sure. And then don't forget about the bottom one, everyone. This is big now in neurology research, and it's big in the terminology. And this is on the spectrum of MS, and that's called neuromyelitis optica spectrum disorder. It's when it affects the central nervous system as well. And so neuromyelitis optica spectrum disorder is often misdiagnosed as MS or perceived as a type of MS. However, it's a distinct condition. It's going to affect the cord, probably more so than the brain. So now they have antibodies to look at, and they've now differentiated MS differently from clinically isolated syndrome, differently from neuromyelitis optica spectrum disorder. And then here it is. This is called Devic's disease, neuromyelitis optica spectrum disorder. And you can see here's the things that we talked about. They might go steroids for a while. They'll do a plasma exchange for this. They might look at some corticosteroids. They might go Greg, you're big into this. They might go into the immunosuppressive medications with this. So there's a lot of things they can do. But I just want you to know, we're not here to make anybody a neuro specialist, but it's just, I want you to know that MS is different from clinically isolated syndrome and so forth. Okay, and then let's just end it with these last 2 conditions, totally not related to brain tumors, stroke, or optic neuritis. I just don't want you to forget about how important this is, this arteritic ischemic optic neuropathy, this major stroke per se to the optic nerve, but it's not due to the metabolic syndrome of diabetes, hypertension, cholesterol, and obesity. It's due to an autoimmune disease. Anytime you get this major stroke with pale swelling, arteritic anterior ischemic optic neuropathy, very dangerous for death, very dangerous to go to the other eye within days. Both eyes will be blind. It's a pale swelling. And I just want you to know that giant cell arteritis is the major cause in Caucasians, and possibly lupus and polyarteritis nodosa could be in African Americans and Latino Hispanics possibly, and even Asians. So this disease, this giant cell disease that gives you this arteritic anterior ischemic optic neuropathy can also give you other things. One of them, and you can see this is infiltration of the short posterior ciliary arteries with giant white blood cells. It's an autoimmune disease. You see the nerve is pale swelling. You think arteritic versus, don't forget about the non-arteritic, that's something different. But what I just wanted to show you is that they might have headache and scalp tenderness and jaw claudication and night sweats. Those all could show giant cell arteritis, arteritic ischemic optic neuropathy. There it is again, that white, swollen, let's say pale colored with a cotton wool spot. And then they're going to do the SED rate. They're going to give them steroids to keep the other eye okay. Giant cell can also give you artery occlusion. Giant cell can also give you cilioretinal artery occlusion. This is a big one. You got a cilioretinal artery occlusion. When I saw this in retina, the biggest fear they have with cilioretinal artery is boom, giant cell. Because remember, giant cell does not affect small arterioles that you're viewing. These are mainly arterioles and venules. It only affects medium and large. And the cilioretinal artery coming from the choroid is a medium-sized artery. So anytime you have a cilioretinal artery occlusion, you think giant cell. Whenever you have a central retinal artery occlusion, you think giant cell first. And this is the typical non-arteritic. This is not giant cell. This is from low blood pressure in the morning and some other things. All right, they're going to treat it with steroids, methotrexate if needed, and always suspect recurrence. So always look at the other eye with giant cell. Okay, everyone, and here's our very last condition. It's what I told you earlier. Let's go back. Remember the venous sinuses? Hey, Greg, do you want to do a poll question before the last case?
Yeah, let's do that to kind of,
Okay.
Stay compliant in a sense, live and interactive. All right. Thanks, Carlo, for
You're welcome.
remembering. All right. Patient is found to have a retinal embolus during a dilated fundus examination. What percentage of stroke per year? 1, 4, 8, 70. Not sure. That's why I'm here. And then the fun question is, I will wear a costume for Halloween. Carlo, we have a question. It says, cranial nerve number 1, it's divided by 12. Is that part of the syndrome?
It's interesting. It can go into 1, but neurologists don't put it in there. Why? I don't know. But whoever said that, congratulations. I was trying to hide that up, but you caught it. Yeah, cranial nerve 1, they don't put it as a midline stroke. Remember, midline strokes, 3, 4, 6, and 12 are associated with motor problems, eye problems and movement, arm and leg and things like that. But 1 does go into 12, but they don't put the olfactory in there. And I'll tell you why though, because remember, and I'm saying this in a nice way, I know you know this, whoever asked the question. Remember, cranial nerve 1 is not in the midbrain pons or medulla. Those cranial nerve 1 is in the olfactory bulb in the frontal lobe. So I think that's why they don't include it. Those were midline brain stem strokes.
All right, here's the answer. Looks like we got 8% here, or 8% being the majority, and we have about 23% going to wear a costume. Let's just do the last polling question, Carlo, since
sure.
If you're okay with that. We'll just launch it, see if any other questions roll in. And what percentage of patients eventually get optic neuritis after an official diagnosis of multiple sclerosis? And then the fun question is, I like sushi, yes or no? And not seeing any other questions. Going back, looks like Joe launched the handout a couple times. Thanks for doing that, Joe.
You're welcome.
The handout was in the 6:45 email, and it will be coming in the post-event. All right, so let's just end the poll. And I'll share the results. Carly, you might want to review that. Looks like we're kind of all over the place with the answers here. And then liking sushi seems to be just barely majority at 61. So the percentage when you have optic neuritis of multiple sclerosis.
Yeah, it's 50%, right? So majority of people got it. Yeah. So at some point, 1 out of 2 is going to have an MS is going to, a diagnosis. 1 out of 2 will get an optic neuritis. Yeah, either retrobulbar or papillitis. Retrobulbar way more common than papillitis. Okay, great. You want me to do the last case here, and then we're
Yeah.
Yep.
okay. So remember, I'm going to just show you this one more time, everyone. You remember I showed you this early on. The venous sinuses drain the blood of the head of the cerebral cortex, and they also drain the cerebrospinal fluid. And remember, the superior sagittal sinus and the inferior sagittal sinus, they're going to drain into the confluences of the sinuses here, and then basically go into there's a straight sinus will come in, and then they'll go into the sigmoid sinus, and then they'll go into the internal jugular vein on either side. So those are the dural venous sinuses. So let's go back again. So you see this picture on the right. This is a patient with a BMI of 29, I don't know, 28, I don't know. It's not very high. It's overweight, but not obese. Okay. But this young woman comes in and she's Caucasian. She's taking a birth control pill of estrogen and progesterone, or both, combo. She's a smoker, about 5 cigarettes a day. I already told you her body habitus. She doesn't exercise, and she was known to have factor V gene mutation. As you know, that's a clotting problem in many European whites. This woman's Caucasian. So when you see this swollen optic nerve, her blood pressure is normal. So it's not a grade 4 hypertensive retinopathy. You don't see any other hemorrhaging, cotton wool spots, exudates, or edema. So you have to say to yourself, okay, you're not an obese patient in the 40s and 50s on your BMI. You're under 30, you're overweight. You don't have a quick weight gain over time. There wasn't anything like that. But this woman, she complained of headache. She complained of the pulsatile tinnitus or tinnitus that you get at times. She didn't feel very well. And, you start to think, okay, remember what I said earlier, maybe there's a blood clot in the venous sinuses. And you can see on this particular MRV where the arrow is pointing, there's a blood clot here, a pretty large blood clot. And so if there's a blood clot there because you have a smoking history, you don't exercise, you're a little overweight, and you have factor V gene mutation with the birth control pill, you're forming a blood clot up in here. And the cerebrospinal fluid can't drain, and the intracranial pressure is going to go up. And so what they will do first, and you all know this, they're going to do MRI to make sure it's not a tumor. And then once the MRI is clear, they'll do a lumbar puncture. You all know that. And then they're going to look for inflammation, make sure it's not a meningitis and things like that. And then they're going to do MRV if necessary. And this MRV showed that this woman had a venous sinus thrombosis. Some people call it a cerebral venous sinus thrombosis. And at times, everyone, Diamox could be detrimental here. Diamox could hurt the patient because you'll make the clot bigger because you're taking out the fluid. So you got to watch. But anyhow, you see here, they will have headaches. They can even have stroke symptoms if the clot gets big enough. And what's the prevalence? 5, it's not that prevalent. 5 out of every million per year will get a venous sinus thrombosis, but it looks just like pseudotumor cerebri, probably a variant of it. But take a look. These are the people who get them. Factor V gene mutation. 10% of the 10% of the Caucasian in this country have factor V gene. So you might get this, Factor V gene mutation can give you a CRVO, central retinal vein occlusion. Factor V gene mutation can give you an artery occlusion. It can give you other problems. Lupus patients tend to get these. Cancer patients tend to get these. Patients who have cancer that are on chemo drugs tend to get a cerebral venous thrombosis. And also people who have staph infections in the cerebral hemispheres. These are the main group of people who end up with this. But in this particular case, let's say she had other factors. You don't want to smoke, all those things that we said. Smoking's not it. So what did they give her? They diagnosed her with the MRV, first the MRI, first the lumbar puncture. They diagnosed her with a venous sinus cerebral thrombosis. They gave her initially intravenous heparin. And then after that, they put her on long-term Coumadin for an extended period of time. And I can't remember, the literature will say, and she's going to be probably with the hematologist as well and a neuro ophthalmologist, but she has to come in for her spectacles and her visual fields and so forth. So you get to see that patient again. But the point is that, you know, we don't always want to think brain tumor. It could be a brain tumor. It could be meningitis. It could be pseudotumor. It could be tumor cerebri. But don't forget about a venous sinus cerebral thrombosis. And then they put her on Coumadin, and some people have to stay on it all their life. Some people can come off of it depending on what the physician thinks. So that being said there, everyone, we don't forget about your venous. Could we, go through there? And then look at this, a swollen optic nerve. I already said it. MRI, lumbar puncture, MRV. If you need to get the field, see how much visual loss is there, how big the blind spot is, or some other things that are occurring. And always check the blood pressure with a swollen nerve. Always check the blood pressure. In this particular case, everyone, I'm not suspecting a grade 4 hypertensive retinopathy because I don't see a grade 1, 2, or 3. But always check the blood pressure. It's very important. And give all that information to the neuro ophthalmologist or whoever you're sending it to, and you go from there. So hopefully I don't have this picture until a few months from now, but this is exactly outside my window at Elkins Park. This is what I view every day. And it's a beautiful picture, but it lasts too long. So for those of you that don't have this, congratulations, but it was a pleasure. Thank you for your attention. If you have any questions, I think there are some in the chat. Where's the headache? Is it near the thrombosis? Well, it can be, or it can be referred. That's a good question. And I don't know what is andiamo. So I know what andiamo means, but let's go. So, but yeah, that's a good question. It could be near the thrombosis, possibly. All right, guys, thank you very much. There's another question. Is that up there?
No, you're starting to get your virtual round of applause.
Oh,
Carlo, do you want to make, as I switch over, do you have a short regarding the blue blocking? Do you want to make a comment on that, or
yeah,
I'll switch over. If you stop sharing, that'd be great.
okay. Okay, yeah. You want me to talk about the blue blocker?
Yeah, but stop sharing your screen so I can flip over to
Oh, okay, sure. Hold on 1 second. Okay, you good there?
Yeah, thank you.
Okay,
Yep.
good. So the question is that everyone that's on here is going to have an opinion, and we obviously, that's a no-brainer, but there's a big debate here about the blue blocker. All I can tell you is it's split 50-50. Does that make sense? So there are many doctors who believe I got to put the blue blocker. I think, and that not only do they want blue blocker, Greg, in the spectacles, but they want the blue blocker in, the IOL when that occurs.
Right.
But there's a debate. I can tell you that the guy that I train with did not believe in blue blockers. They didn't. But we could have another nice 4-hour debate on why you should or why you shouldn't. But it is,
I think a good way to maybe sum it up and see if you agree with this. I think, when you're talking about blue blocking and you think you're going to prevent by looking at a screen here for the last hour and a half, as we've been doing, or 2.5 hours, or am I creating macular degeneration? Is there enough intensity coming out of there? Yeah, I think the answer is no. But I think, blue blocking in COVID has taught us that in some people, when they wear the blue blocking lenses, the comfort, the dry eye symptoms, those type of symptoms, might be lessened from, blocking that blue light. And then it comes down to, I think the controversial side is, are we affecting our circadian rhythms and so on and so forth that's out there. And I think that's where you get the 50-50. So are we causing macular degeneration? Are we, putting blue blockers on and saying we're going to prevent macular degeneration? Probably not. Comfort, dry eye, staring at a computer. Some people have proven us that does help them. And then all the other stuff I think is debatable. So I think that's probably a good way to sum it up.
Yeah, and I think you bring up a really good point. If you look at it one way, I think you have to look at it from how much blue light is going to affect, that's why lutein, zeaxanthine, and mesozeaxanthine play a role. And then you also bring up another good point. Does the blue blocker affect the retinohypothalamic tract in any way?
Right.
And what I mean by that is if it's in an IOL. And so that's why you're right, it's correct. You can get a debate on AMD, you can get a debate on the retinohypothalamic tract, there's and that's why I think like it's not easily answered, but it's interesting though,
Yeah, I just want to address it that, we hear it all the time. There is debate and, is it a bad thing to put it on there? I would say no. But are you getting as much bang for the buck? Stay tuned. So
yeah, do no harm.
Exactly. Carlo, I'm going to say thank you. I don't see any other questions rolling in here. So thank you. You did a great job as always. Love having you as a speaker. That Carlo and I went to Gannon. He was 1 year in front of me. We followed him through optometry school. And 20 some years later, Carlo, I'm still learning from you. So thank you for doing neuro ophthalmic disease and optometric practice.
Yeah, thank you, Greg and Joe and Vanessa and everyone. Thank you for the invite. And I hope I see all of you in Boston next week. So safe travels if you go and have a good year ahead. And thank you again for the invitation here.